Well, welcome everyone. Thank you so much for joining us today for a public forum to elevate endometriosis to a public health crisis. I'm Katie Schubert. I'm president and CEO of the Society for Women's Health Research. And SWHR is a national nonprofit dedicated to advancing women's health through science, policy, and education while promoting research on sex differences to optimize women's health. We are so pleased today to have three distinguished speakers to join us for the event. Dr. Idalise Flores, Professor of Basic Sciences and of Obstetrics and Gynecology at Ponce Health Sciences University, Puerto Rico. Dr. Jim Seegers, Professor of Gynecology and Obstetrics and the Director of the Division of Reproductive Science and Women's Health Research at Johns Hopkins School of Medicine. And Jenna Reich, Founder and Executive Director of the Endometriosis Coalition. I'd also like to thank the sponsor of today's event, Sumitomo Pharma. SWHR maintains independence and editorial control over our program development, content, and work products. And as always, we are live tweeting today. We invite you to join us using the hashtag SWHR Talks Endometriosis on all social media channels. And at this time, I'd like to introduce SWHR's Chief Science Officer, Dr. Irina Ninye, who is moderating today's event. Irene.
Thank you, Katie, and welcome everyone. Endometriosis is a chronic gynecological condition that affects more than 200 million women worldwide, from adolescence through menopause. With tissue that resembles the uterine lining growing outside of the uterus, it can form lesions that cause pain in your pelvis and back, pain between periods, and pain with intercourse, as well as affect menstrual bleeding and infertility. Endometriosis can severely impact a patient's quality of life, and due to societal stigma around menstruation and gynecological disorders for many women, the disease often goes undiagnosed and undertreated for years. SWHR's endometriosis program was founded to draw awareness to research gaps and unmet needs in clinical care, education, and policy concerning endometriosis. Last fall, SWHR convened an interdisciplinary working group of researchers, clinicians, and patient advocates with expertise in endometriosis and gynecologic health for a roundtable meeting to develop strategies to address these gaps. The working group met with policymakers on Capitol Hill and collaborated with SWHR to develop an endometriosis toolkit for teens. Today, we have three members of our endometriosis education working group with us to share outtakes from the roundtable, as well as their expertise as to how we can better understand the clinical and public health impacts for women living with endometriosis. Following the speaker presentations, I will be moderating a discussion with all of our panelists, so we invite you to use the Q&A box to submit questions throughout the event. We will try to address as many questions as we can during this program, especially submissions that cover recurring themes or questions with broader applicability to our audience. At this time, we will start with Dr. Idalise Flores, who will give us an introduction about endometriosis risk factors and disease burden for women across the lifespan. Thank you for joining us, Dr. Flores.
Thank you so much for the invitation to present. Let me start sharing my presentation. Hi, so I'm thrilled to be here today as part of this webinar. I thank everybody who has connected, and I thank SWHR for coordinating this panel. I am Dr. Idalise Flores. I am Professor of Basic Sciences and OBGYN at Ponce Health Sciences University in Puerto Rico. I have been an endometriosis investigator for 20 years. I am a patient and a patient advocate. I am a board member of the Puerto Rican Endometriosis Patient Foundation, of the World Endometriosis Society, and a member of the Alliance of Hispanic Endometriosis Patient Associations. And I'd like to disclose that I'm co-founder of SUR-180 Therapeutics. It's a biotech company that develops new drugs for endometriosis. Today, I have been tasked to discuss endometriosis symptoms and risk factors, the prevalence, disparities, and disease burden. And finally, I'll talk a bit about stigma and misconceptions about endo. So let's start with the symptoms of endometriosis. What are the signs that should alert about a possibility of having endometriosis? Well, among the most common symptoms are severe pelvic pain that is associated with the period, painful sex during and after coitus, and infertility, which can affect about half of the patients. Pelvic pain can also present between periods, and if it occurs consistently for 6 months or more, it is called chronic pelvic pain. Other common symptoms include nausea and vomiting with the period, and this appears in adolescents in particular, heavy or irregular periods, fatigue, and bloating. Because endometriosis lesions can affect other organs in the abdominal area, like the intestines and the bladder, patients may also report pain with defecation and pain during urination. Endometriosis symptoms are chronic. As you can see, they're multisystemic, they're debilitating and impactful. And it's important to note that they do vary in severity and presentation case by case. But we must recognize the symptoms so that diagnosis can be done promptly and especially among adolescents. Because one common misconception is that endometriosis only affects or primarily affects adult women. But in fact, endometriosis can develop during adolescence, and it's a very common cause of pelvic pain or dysmenorrhea in teens. Studies that have been conducted around the world show that diagnosis takes an average of 7 years since symptoms start, but it is very common to hear from patients struggling with symptoms for 10, even 12 years to finally get a diagnosis. It should be common sense to recognize that it is critical to diagnose and treat these symptoms promptly, as endometriosis is known to progress over time and symptoms become more severe and incapacitating. Apart from the strong component of genetics as a risk factor for endometriosis, research has shown strong and robust associations with early age at menarche, short menstrual cycle length, a lean body size, and greater parity as a protective factor. And there are other potential associations, but we still need stronger evidence because the data is less consistent. And this include physical activity, exercise, diet, and lactation. Multiple studies across the globe kind of agree that endometriosis affects 1 to 10 women and teens, most commonly from puberty to menopause. Regarding racial differences, it has become widely accepted that women of color, either Black women, Hispanic women, have less prevalence of endometriosis than white women, and that Asian women have the highest prevalence. But this notion, however, is not substantiated by strong evidence. There have been very few studies, and the ones that have been conducted so far have shown that there are racial differences, but do not include sufficient number of subjects representing all the non-white patients. And sometimes one study contradicts the other. So perhaps the question should not be if endometriosis is less prevalent in non-white women, but rather if it is less likely to be diagnosed in this group due to systemic factors, misconceptions, or socioeconomic factors. Because health disparities have been documented for endometriosis. In fact, compared to white women, women in color, especially Black women, the diagnosis of endo takes longer. There are lower rates of minimally invasive surgeries, and there are higher rates of surgical complications. And there are well-documented barriers to care that include quite often the dismissal of symptoms by health professionals and support systems, lack of or limited access to specialized care, and the high cost of treatments and surgeries. So these must be tackled to ensure equity in receiving the high-quality endometriosis care in all women, irrespective of race and socioeconomic status. Let's talk about the impact of symptoms they impact women really across their lifespan, from adolescence to adulthood. This impact is evident even at menarche, at the onset of symptoms, for many occurring during adolescence, where patients see a direct hit on their education, school attendance, focus, and participation in sports and social activities. Later in life, during their 20s and 30s, endometriosis symptoms have documented effects on life opportunities, career, professional growth, as well as intimate relationships and family planning. Then during the 30s and 40s decades of life, patients have already been living with chronic symptoms with long-term impacts that manifest as mental health issues, low quality of life, and the financial impact of treatments, surgeries, and assisted reproductive technologies. So all in all, patients spend decades of their lives dealing with multiple impacts with serious implications for mental health and well-being. In this recent review by Mismer et al., it examined the evidence that's available on how the symptoms of endometriosis impact life decisions, the potential through the life course, and major life events. In this figure to the left, the authors summarize the many interactions and interconnections between the life events, including education, career, family planning, relationships, and mental health, with specific impairments brought in by the endometriosis symptoms. And you can see how complex are these interactions, demonstrating the need for multidisciplinary care in order to get meaningful improvements in quality of life. And this study also identified factors that are mediator of these interactions that include the time living with the disease, the severity, frequency of the pain and other symptoms, any comorbidities, and the quality and strength of the patient's support and healthcare systems. In summary, this review of the literature existing so far shows clearly that endometriosis symptoms impact women's lives broadly, and it emphasizes the importance of multidisciplinary care to improve the health trajectory and overall life satisfaction. This is another diagram from the same review. I like it because it presents in a very visual and compelling way a comparison of the effects of endometriosis symptoms on the life course trajectory of a woman living with endometriosis, shown here in orange, with a healthy woman, shown here in the blue line. The numbers in the orange circles represent different life exposures and events that occur from adolescence through adulthood into menopause. The influences on a patient's attainments in education, family, career, relationships, they're shown here as differences in the direction and the slope of the orange line. And this is in stark contrast to the blue line presenting the life trajectory of a woman without endometriosis or a woman that had been treated appropriately. Now, how do we minimize the negative impact of symptoms on a woman's life course? First, by early diagnosis. Second, by providing effective interventions and treatments, which are going to be likely long-term and multidisciplinary. We need access to this type of models of healthcare delivery that incorporate not only the gynecologist as the primary care practitioner, but also other specialists and subspecialists, including expert surgeons, psychologists, mental health specialists, all working together and communicating effectively. We and others have studied the role of stigma in endometriosis. Women with endo often report feeling stigmatized as whiners, complainers, weak, and even hysterical. And sadly, this label was applied across multiple contexts and interactions with partners, family members, health practitioners. As a result of this stigma, patients fail to express the extent of their suffering, and this leads to social exclusion, low self-esteem, high stress, and importantly, in decreases in help-seeking behaviors. And this all contributes to diagnostic and treatment delays. So we must address stigma via interventions to educate and raise understanding of endometriosis at multiple levels, individual, interpersonal, and sociostructural, in order to promote seeking healthcare and to ultimately minimize the impact of endometriosis symptoms. Lastly, these are the key takeaways from this part of this webinar. Endometriosis affects women and teens of all races, ethnicities, and socioeconomic groups. But granted, more research is needed to understand the factors that impede access to high-quality diagnosis and treatment. And we need to include a diverse population that represent all patient groups in research if we want to ensure equity. We need to tackle misconceptions such as that pregnancy or hysterectomy or menopause will likely result in a cure. We need to educate earlier about what is normal and what is not normal about the menstrual cycle so that teens and their caregivers can identify early these red flags of endometriosis and other gynecological disorders. And we must understand that the complexities of endometriosis management requires a multidisciplinary team and a strong support system for patients. So thanks for your attention, and I'm looking forward to your comments and questions at the end of the panel.
Thank you very much, Dr. Flores. Very informative and setting the tone for the rest of this public forum. And now I'd like to invite Dr. Jim Seegers to discuss the processes for diagnosing and treating endometriosis and shine some light on how women can navigate these options for their personalized care plan. Welcome, Dr. Seegers. You're still muted.
Thank you very much. This is typical of my use of Zoom. So thank you again for the invitation to speak today at this wonderful seminar. My topic today is elevating clinical care for endometriosis, and my talk will focus on the diagnosis, treatment, and clinical conditions associated with endometriosis. This is a lot to cover in 10 minutes, and I'll be brief. Most descriptions of endometriosis begin with the phrase, endometriosis is a benign disease. At the conclusion of my talk, I hope to have convinced you that for many women, endometriosis is not a benign disease. In fact, I hope to show you that endometriosis is a systemic disease with lifelong risks. During the talk today, I'll mention some unmet needs for research. And throughout the talk today, I will use the word women because that is a term used by most clinical guidelines and research manuscripts. Though I acknowledge that gender is not binary for everyone, and I do not intend to offend or exclude anyone by use of the term. So the first problem with endometriosis is there's not a non-surgical diagnostic test. Definitive diagnosis requires surgery and visualization of the lesions. Symptom diaries and exams can be helpful, but are not specific. MRI and ultrasound can sometimes provide a high suspicion of disease, but not regular pelvic ultrasounds. For example, an ultrasound examination must be specialized using IDEA guidelines like IDEA, which include additional tests such as the sliding sign and assessment of tenderness or lesions and nodules, methods that go beyond a regular ultrasound examination. Pain is a major symptom, and if you have pain, it's helpful to track symptoms and record them to help guide providers to a diagnosis. The Society of Women's Health Research has produced an endometriosis toolkit that can be used specifically for this purpose. The lack of a non-surgical diagnostic kit and limited availability of extended and focused ultrasound tests results in a delay in diagnosis, as was mentioned before. Under 19 years of age, there's an average of 12 years delay in diagnosis after the onset of symptoms. During this time, the disease can progress and become a deeply invasive disease. In some women, endometriosis invades the bowel, as shown in the upper right. This is a section of bowel removed from a patient with endometriosis. There are many unmet needs, but one of the greatest needs in the field is for a non-invasive diagnostic test for endometriosis. It's important to mention that when we speak of endometriosis, we speak as if it's one disease, but in fact, endometriosis is one disease with many stages. As shown here, there's mild disease, moderate disease, or severe endometriosis. In mild disease, there can be lesions that are present over the back of the uterus. This is shown from the inside or the ovary. But in severe disease, you can see that there's adhesions, or the pelvic organs are stuck together. And in some cases, endometriosis can even progress to cancer. One of the worst statistics about endometriosis is that treatment is often delayed. It takes an average of 7 visits just per patient to be referred to a specialist. More concerning is that in one study, half the gynecologists did not even think that early diagnosis was important because there was no treatment. That is not correct. There are treatments for endometriosis. In fact, there are several treatments for endometriosis. Pain medications, of course, can be helpful for symptoms and reducing inflammation. Hormonal medications can relieve symptoms and in some cases help to arrest progression of disease. Alternative approaches, including acupuncture and pelvic floor therapy, can have helped very many. And surgical resection, particularly if it's resection, can often relieve the symptoms. Medical treatments approved for treatment of endometriosis in the United States include Lupron and Zoladex. These can be used short-term. And there are oral medications such as Orlistat that is approved for 6 months, or Myfembree that can be used for up to 24 months. These hormonal medications act at the level of the brain to reduce the hormone estrogen and its production by the ovary. And therefore, the estrogen reduction can reduce the growth of endometriosis lesions. These medications are highly effective and provide pain relief in over 80% of women, but some do cause hot flushes and some can lead to long-term bone loss. As I mentioned, surgical resection of the lesions results in pain relief for most women, but many women will experience a recurrence of the pain and lesion regrowth years later. Hysterectomy has been used in the past, but endometriosis can persist even after hysterectomy and occur even after menopause. Endometriosis causes inflammation and stress to the immune system of women that are affected with the disease. This activation of the immune system is believed to be the reason why there is a 1.5 to 2-fold increase in cardiovascular events in women with endometriosis, as shown in the lower right-hand corner. Immune activation is also believed to be the explanation of why women with endometriosis have increased risks of systemic lupus erythematosus, rheumatoid arthritis, and hypothyroidism. There's also an increased risk in ovarian cancer, endometrial cancer, and melanoma in patients with endometriosis. And an important point that was mentioned before is that 95% of women with endometriosis have disease comorbidities, that is, diseases that are caused by or associated with endometriosis, such as fibromyalgia, chronic fatigue syndrome, irritable bowel syndrome, depression, migraines, or anxiety. So what is needed then is a new approach to the treatment of endometriosis. In the past, the focus was on symptoms, but as I've shown, left untreated, endometriosis can progress to more severe stages and lead to activation of the immune system, causing immune conditions, autoimmune conditions, comorbidities, or in some cases, even cancers. What is needed is the focus on eradicating disease with an earlier diagnosis and earlier treatment of the affected women. A new approach is needed for endometriosis because it affects 10% of women in the United States. With our current approach, the cost to the healthcare system by endometriosis is staggering, $110 billion per year in the United States alone. Furthermore, in addition to the pain and suffering of women with endometriosis, the average woman pays approximately $12,000 for medical care related to this disease. These cost burdens resemble those of diabetes and rheumatoid arthritis. The photo on the right shows our Capitol with people advocating for a cure for endometriosis. So in conclusion, I hope that I've convinced you that endometriosis is not a benign disease. In 2 to 6% of women affected with endometriosis, they will have an endometriosis-associated cancer. There are many unmet needs, including for diagnostic tests and an effective treatment. We need a new clinical approach to this disease. I want to thank you for your attention and thank you for your patience as I stumbled through the slides.
Thank you, Dr. Seegers. And you did fine. Please note that those who are tuned in live today can submit questions at any time using the question and answer function within the app, and we will try to address as many as we can during the panel discussion portion of the event. I also wanted to note that we are recording this webinar and we'll be sending out a recording to all the registrants and posting it on our website. And so now I'd like to invite Jenna Reish to share her personal journey with endometriosis and how it is tied into her passion for advocacy work in this space.
Good morning. My name is Jenna Reish. I am a registered nurse of 15 years, currently working in internal medicine, family medicine for the last 4 years. I am the founder and executive director of the Endometriosis Coalition. We're a 501c3 nonprofit whose mission is to raise awareness, promote reliable education, and increase research funding for endometriosis. So I'm going to present from a patient perspective. We had 2 really great practitioner perspectives. And though I am a practitioner as well, I believe my perspective is unique in that I've played both parts and are able to see our system in 2 different ways. So I'm going to share my screen to get into my presentation. Okay. So my endometriosis origin story is a little bit atypical in that my first presentation of symptom was not pelvic pain. I had relatively normal periods all the way up until the age of 27. Mind you, I was on birth control for birth control reasons up until that time, from 18 to 27. And that is when I experienced my very first endometriosis symptom, when I stopped taking the birth control pill. I will never forget it. It is a day that's etched in my brain forever. I was driving to work and experienced a very sharp, intense pain in the right upper side of my stomach, took my breath away, and also caused some shortness of breath. I went to the ER at work, got the whole workup done of looking at everything in my abdomen, my gallbladder, anything that was in that anatomical area, and everything came back negative and inconclusive. And so I went home and was told to follow up with my PCP, and so I did that. The symptoms resolved over a few days, and then the next month they came back, and then the next month they came back, and then the next month they came back. And after about 4 months of this pain coming back, this very sharp, intense pain of the right upper side of my stomach that would take my breath away and would feel quite literally like someone was stabbing me in the stomach, I noticed that it was synced with when I was getting my period. I would get this pain about 2 days before my period would come. It would get worse and worse each day. My period would come, and then the pain would slowly start to come down over the next 3 days. So I took these complaints to my gynecologist, who no fault of her own, looked at that and said, well, those two areas aren't anywhere near each other, and I can't really see why there would be a connection. And so I went on with life living this way for the next few years with this cyclical, take your breath away, stabbing abdominal pain. But over time, it got worse. The pain became more frequent. It started coming earlier and lingering around a lot later. I also started developing pretty significant shortness of breath and a right shoulder pain in my scapula that when I would lay on my back, it felt like there was constantly a rod in my back. And so over the course of about a year or so, this pain went from cyclical to basically every single day. As time continued to go on, I had a progression of different symptoms, really terrible fatigue, very bad constipation, painful bowel movements, nausea, brain fog, bloating, pain with sex, this constellation of symptoms that showed up over the course of a few years, all while I was being told that, you know, everything was fine, that nothing was wrong with me. So over the course of about 3 years, I lived with this progressive pain and these progressive symptoms until I couldn't anymore. And so once I got to this point, my primary care practitioner, who was absolutely fantastic, thought that it was time to really look into what was going on with me. So she sent me to a new gynecologist who explained that there's something called endometriosis, and sometimes people have it in their diaphragm, and that could be why I'm feeling what I'm feeling. But they wanted to make sure that it was absolutely not anything else before we even attempted to treat this possible thing with anything outside of birth control and ibuprofen and pain meds. At this point, I'm no longer able to work. I'm on complete disability from work because my symptoms are so dysfunctional. Throughout this time for my workup, I saw a plethora of specialists. I saw 3 different gynecologists. I had my primary care provider as kind of my quarterback through this. I saw a pulmonologist. I consulted with a cardiothoracic surgeon. I saw 2 different cardiologists, a regular cardiologist and an interventional cardiologist, a pelvic pain specialist, and a gastroenterologist. Everyone's tests kept coming back inconclusive, except some incidental findings on the cardiac side, but otherwise everything was completely normal. And so we were just reaching dead ends, test after test after test, and I'm feeling worse and worse and worse. Over this time, I also had multiple procedures, pulmonary function tests, a colonoscopy, a cardiac catheterization, which I should highlight is usually reserved for not someone that's 27 years old. It's usually something for people with cardiac problems, working them up for blocked blood vessels. So this was a very invasive thing for us to be doing, but I was so sick that everyone felt it was necessary that we try to get to the bottom of it. I had multiple stress tests and echocardiograms. At the end of all of this, I had never had a diagnostic laparoscopy. Up until this time, we had just assumed, based on the pelvic pain that I was having, that I may have endometriosis and treating me with different birth controls, and I wasn't getting any better, but we'd never done a diagnostic surgery. So finally, we decided to move forward with one, and at this time, I was not as versed about the different surgical techniques for endometriosis treatment, and I had what is called an ablation surgery in 2015, and at this surgery, a positive specimen for my right diaphragm came back for endometriosis. So then at this point, now that we have a positive biopsy, I am offered Lupron, which I take for 3 months, suffered very terrible side effects and did not feel any better and felt I was at a dead end. All the tests were negative for anything else but endo. These treatments weren't working, and I decided I need to look a little more into this diagnosis that I don't really know about because I trusted my care providers as one should. Excision of endometriosis, and found my way to the Center for Endometriosis Care in Atlanta, where I had excision of endometriosis in multiple areas, including my bowel, my bladder, my uterosacral sacral ligaments, my abdominal side wall, and I also had a video-assisted thoracic surgery, which found very, very deeply infiltrated endometriosis in my right diaphragm. So as you can see from my journey, from a patient perspective, it's really important that they have an entire healthcare team to help them figure out what's going on and how to best manage it. The primary care provider is very important to kind of be that core person to help order consults and different tests. A gynecologist specifically, and hopefully one that is well versed in understanding endometriosis and endometriosis care. A physical therapist, a gastroenterologist, sometimes a radiologist, mental health, urology, basically any organ system that endometriosis may be affecting, because as we know, it affects every organ in the body, it has been found in every organ in the body. We need a care team that's built around handling the idea that this is a full body disease. So I realized as a nurse become patient, we're never really taught how to advocate for ourselves. And why would we be? I don't think we go through life thinking we're going to be in a position where we need to know more about the disease that's affecting us than the people taking care of us do, or that it happens that we end up knowing more about the disease than the people that take care of us do. But nonetheless, we're never taught how to do this. And so we are basically acquiring skills that we were never trained for along the way. And I felt that my medical background helped me to do this in a way that I know most patients did not have. And some things that I learned along the way that were very helpful for me to be my own best advocate, because I am the expert on me, as my mentor, Heather Goudon, says so expertly. These are the things that I use to help me be the expert on me that I think could be helpful to patients and providers as well. So one is to learn to trust yourself. There is a lot of, the buzzword is gaslighting, but it's very real and very pervasive in the endometriosis world, in which we're told that our symptoms are in our head, that they're not that big of a deal, that they're normal. And I'm here to tell you that they're not. Excruciating pain is never normal. Excruciating pain that keeps you from functioning is never normal. So trust yourself. Two, empower yourself by learning as much as you can about endometriosis from trusted resources. And the trusted resources is the most important part here, because there is a lot of misinformation about endometriosis out there. And thankfully, there are organizations like SWHR that are creating resources to help us better navigate information that we can trust. Keep a symptom tracker to log any trends in your symptoms. It's very helpful for a doctor to see that you are keeping a close eye on when things happen, what affects you, is it triggered by something? The more accurate of a historian you can be, the better you can help your care team help you. I suggest making a list of questions you want to ask in advance of appointment so that you don't get flustered and forget anything. Bring someone that you trust as a second set of ears, because even if you are completely present, it is a very overwhelming situation and you almost always will forget something. So that second person can kind of help you digest all of that after the appointment. I suggest taking notes during your appointment. And if you are an audible learner, I suggest running it by the provider. If you could record it so you can listen to it later, I find that very helpful. Ask questions to clarify things that you don't understand, because you understanding your care plan is the most important part of being an advocate for yourself, so you can make informed decisions. And lastly, get a second, third, fourth, fifth, sixth, seventh, eighth opinion. If something doesn't feel right, listen to that. Keep pursuing until you get the answers that you deserve. So my journey with endometriosis really led me to see that there was a gap in the space of patient representation when it came to nonprofit organizations that I felt looked like the people that the disease was affected by and spoke for the people that the disease was affected by. And so in 2017, I started the Endometriosis Coalition. We are a patient-founded, patient-focused nonprofit organization with the mission to raise awareness, promote reliable education, and increase research funding for endometriosis. The Endometriosis Coalition is involved in a lot of things within the endometriosis community, but our two most recent programs that we're really excited about is our EndoCo Patient Support Group, which is a professionally led psychiatrist support group by someone who is also part of the endometriosis community. And the goal of this group is to provide the opportunity for endometriosis patients to share their personal experiences and learn coping strategies. And some examples of the things that we discuss there are acceptance, mindfulness, distress tolerance, We meet the last Thursday of each month, and we have gotten really great feedback that it's a consistent, safe space for patients to come and learn coping strategies and just really just share and be seen with people that understand what they're going through. And then the second initiative we're really excited to launch this spring is the EndoCo Patient Grant Program. The financial burden on endometriosis patients is absolutely astronomical. As Dr. Seeger talked about, some of the treatments that we are given are not covered, excision surgery being one of the biggest ones. But on top of that is medications and physical therapy and copays, and it all can be very daunting and very overwhelming, especially when so many of us end up not being able to work. So it was always a passion of mine, a long-term goal of mine, for us to be able to help in a financial way. And through some very, very generous grants and donatees, we are able to launch our very first of its kind endometriosis patient grant program, which applications will be launching in April 2024. And then lastly, just to look at what we've accomplished over the last year as an organization that is fully volunteer run, made up of other people who have endometriosis and are just very passionate about educating others, creating resources, creating community. We were able to host multiple screens of Below the Belt in conjunction with Shannon Cohn. We were able to launch our virtual patient support group. We received an amazing donation grant from the Every King of Baton Rouge Fund to start our teen-specific endometriosis grant. One of our members served on the Department of Defense peer review medical research program as an endometriosis peer reviewer, which we're really excited to be part of that program. And, you know, that's just a fraction of the work that we do and the things that we're looking forward to. And I just want to round out my presentation by saying that this disease, like Dr. Seeger said, is not a benign disease. It is a very serious full body systemic disease that so many of us end up with these different comorbidities due to. I'm one of those people that ended up with pelvic floor dysfunction and small intestine bacterial overgrowth and now 2 different autoimmune diseases. And all of our goal is to prevent people from getting to that place where this disease causes so much destruction that there's no turning back. And the way that we do that is by platforms like this, education, fighting for research, fighting for funding, fighting for the right to good care. Thank you so much.
Thank you so much, Jenna, for sharing such an empowering story and call to action. And thank you all for sharing and setting the stage for the question and answer portion of this public forum. We invite the panel to all turn on their videos and at this time. And again, we invite participants to continue to submit questions using the Q&A function within the app. We'll try to address as many as we can in this time frame, but we recognize we might not be able to get to them all. Please also note that our conversation today is intended for educational purposes and is not intended or implied to serve as a substitute for medical, professional, or legal advice. I'd like to start with a question about that came in about the association. Is there an association with endometriosis and other conditions like PCOS, adenomyosis, or obesity?
Irene, do you want to call on whoever you want to answer the question?
Yeah, so thank you for that. I guess, Jim, if you want to, and then Idalise, if you want to, pull on that one.
So there, adenomyosis and endometriosis sometimes go together, and they can be, and you can have PCOS, you could have other conditions that exist with endometriosis that's not a one-to-one or anything like that. Many women, fibroids can coexist with endometriosis, so just because you have a fibroid doesn't mean you don't have endo. And the other thing I'd like to say is that I want to just debunk one thing that's people sort of think about is that, well, that certain races don't get endo. That's a bunch of mahoney, okay? The women of any racial group can get endo, and women that are having pain, it's not normal. So There have been some, I've answered some things in the chat. And again, these are not medical advice from a person that's for your own individual care, but hypothetically, if you know, these are things that we would do. If you have pain, it's not normal. You should get a scan and you should advocate for yourself. And I think Jenna did a great job of saying how, as a nurse, she understands that that's the case. So advocating is really important, and you don't have to suffer. So I'm not sure I answered the question.
No, that's very good. Actually, I might spin it to you, Dr. Flores, if you are familiar with any non-invasive diagnostic tests that might be emerging in the endo field.
Just to add a little bit of the previous questions, and yes, many women with endometriosis are going to present other conditions that also cause pelvic pain, and sometimes that makes it, complicated and difficult to get the diagnosis, and that includes irritable bowel syndrome, Crohn's, interstitial cystitis. So not because you have endometriosis doesn't mean you can't have a plethora of other conditions. So it's very important you get a good examination, because there could be multiple sources of the pelvic pain, and they all have to be treated in order for you to be treated properly. And regarding a non-invasive diagnosis, this is something that I've been doing a lot of research for many years. It's like the golden grail kind of thing that everybody wants to get into. Research-wise, it's been very complex, very difficult to get something that's non-invasive, highly specific, highly sensitive. In my experience, sometimes you see some research out there with small groups of patients participating. When I say small, less than 50 or less than 100, and it shows beautiful data, beautiful specific results. But then when they move up to thousands of patients, sometimes those signals get then lost, because endometriosis is such an heterogeneous disease. So then when you add multiple symptoms and different conditions that are affecting the same patient, they're likely going to impact some of these markers. So yes, there are some studies going on in some companies, interesting companies that we're following to hopefully see that something pans out. We all want a non-invasive diagnostic. We just need to see the data.
Thank you. And this question I have for you, Jenna, is how has your experience or your challenges with endometriosis changed over the years? And, what advice would you give to someone that's early in their journey of finding out that they have endo?
I would say that it's changed over the years in that it went from having absolutely no idea what was going on with me, being undiagnosed for years and years and years, so feeling very kind of helpless, hopeless, and just stuck, to having a name for what was wrong with me, which was validating, then to confusion on what am I supposed to do about this now that I know what it is, to more confusion because there's so much conflicting literature about what the best thing I should be doing is, to a place where I felt like I needed to be the driver of this, because clearly not being the driver wasn't getting me anywhere. And so with that, learning as much as I could, learning about multidisciplinary care and different procedures that could be helpful to me. Excision surgery for me was the cornerstone of getting better. I had mine in 2016 and have not had a recurrence of symptoms since then. But like I said, and like Dr. Seeger said, so many other things are wrong with my body from, not having the disease addressed for so many years. And so now I'm on the other side of the endometriosis acute pain, but I'm dealing with the fallout now. And that's the part that kind of keeps me here in this work, is knowing that it's not just the disease and the lesions. There's so much more to it than that. And trying to be on the side of things where we help really try to figure out the whys of this. Why is this even happening in the first place? Like, that's what drives me to still be in this advocacy world. And so I guess I went from novice endometriosis patient to expert advocate over the course of about 10 years. And it's really hard work, but I'm seeing over the years that patients are becoming a lot more educated and a lot more comfortable, asking the questions and getting the answers that they need. And that's been really, really great to see.
And as you talked about, that journey, I want to, dovetail off of that, Dr. Seegers. And what does endo look like post-menopause? Is it something that someone can still have, or do the symptoms subside? What can a woman expect in life?
So it's rare. I mention that because I think a lot of women think that once they have hysterectomy, they're done with it. And then where problems can arise is that if they have continued pain after hysterectomy, if they have lesions that occur after surgical removal or hysterectomy, and by that I'm talking, all tissues are gone except for maybe the ovaries, depending upon whether the ovaries were removed. But the presence of the ovaries, and specifically in cases where endometriosis is not totally resected, can grow postmenopausally, and that is something that people don't tend to think of. So I throw it out there just in case there are women who are suffering, who had a hysterectomy with endometriosis, are suffering with pain after hysterectomy with endometriosis, and thinking my endo is gone because I have my uterus out. But maybe they had the ovaries, or maybe they took hormonal replacement therapy, and now they're having pain. And this is something that's very difficult for providers because they don't think of it. It's not in a differential diagnosis, and that can be a problem. So I hope that answered the question.
No, that was great. And I know, Dr. Flores, you mentioned that non-invasive diagnostic tools are, that's your home territory that you've really been working on. And I'm interested to know from the patient perspective, Jenna, if you could get on a research soapbox, what would you like to see investigated when it comes to endometriosis?
I would like to know why it happens. I think if we understand the why, then we can have treatments that actually address the disease itself. Outside of surgery and removing the disease, can we prevent it from happening at all? Is there something we can be screening for the way that we look for colon cancer and breast cancer? I think that we are very reactive with endometriosis, and I think the disease is serious enough that we need to be proactive in how we are approaching it.
Thank you. And so I know we're coming close to our time. And so before we wrap up, one last question for each of you. We get women and general audiences, researchers, healthcare providers, industry policymakers that all tune into our events. What is one takeaway that you would recommend to one or all of these viewer groups to help them better support women living with endometriosis? And so we'll start with Dr. Seegers, then Jenna, and then Dr. Flores.
Well, I hope I've been pretty clear. I think that we really need to change the way we attack this disease and to address it clinically. The most pressing need is for a non-invasive diagnostic test that is highly accurate. But it doesn't stop there. We also need a cure. And I agree with Jenna about that.
Yeah, I would say the acknowledgement that this disease is a very serious disease, that it's not benign, it's not just a painful period, it is so much more than that. It affects the entire body. And then until we start approaching it that way, millions of people are suffering for almost no reason. I feel that way at this point. We have so many things at our disposal to help figure this out. And I know that it's possible. We just need everyone on the same page to agree that it's important enough to figure out.
We need to go beyond stigma and taboos. We need to start talking earlier on about menstrual health and menstrual education, identify what's normal, what's not. We need to discuss this openly in society. Otherwise, the diseases or the conditions are not going to be diagnosed or cured on time. We need to be empathetic. We need to understand and validate these women that are telling us that they feel this pain that are not allowing them to live their fulfilled lives. We need to validate this sentiment, these symptoms, even though if they're invisible and we don't have a way to measure this pain. So we must validate, be empathetic. We need to support these women in their journey and understand across the board that this is a complex disease to treat, and therefore the road is going to be challenging, but there are options that we can give these women. But supporting them in this path as caregivers, as friends, as partners, our doctors is of utmost importance.
And actually, I know you said that was the last one, but I just wanted to quickly, maybe, Dr. Seegers, you'd mentioned benign, and we've used that word a lot, and a lot of people associate that with cancer. Can you just, in 30 seconds, distinguish whether or not endometriosis, the implications with cancer or not? I just want to clarify that.
So I'm sorry, can you, I sort of missed the.
Oh, so we've mentioned the word benign, and a lot of people associate benign with cancer. And so I just wanted you to just take a quick moment to discuss the cancer association with endometriosis. I don't want people to think that it's different
So,
from.
thank you very much. So endometriosis is not cancer. What I'm saying is that if you look at Webster's dictionary, what the definition of benign is something that does not affect the health adversely, something that does not cause systemic reaction like a cancer does. Cancer causes systemic reaction. We oftentimes, if you will, succumb to cancer because of the reaction of our body to the cancer, not necessarily the cancer itself. And endometriosis does that, activates the immune system. And then in some cases, as I mentioned, endometriosis, because of the stress on the body, other cancers develop. So there's an increased risk of endometrial cancer and other cancers associated with endometriosis. And then sometimes endometriosis itself can become cancerous. In 1.6% of cases, the lesions themselves can grow from an endometrioma and usually an endometrioma, and turn into a cancer in that lesion. Usually those lesions have cancer driver mutations, which is a whole nother topic, but in most cases, so in 98% of cases, endometriosis is a benign disease. If you have a lesion that's persistent over time, that it grows 3 to 6 centimeters of an endometrioma, then those lesions have a higher incidence of endometrial cancer. If you have a lesion that's persistent, then that's obviously something to be concerned about. Did that answer it, Irene? I'm not sure if I got it.
No, that was great. Thank you so much to all of you. You have been an amazing panel. Thank you for your time, your insight, and your transparency. We'd also like to thank Sumitomo Pharma for their support of this event and SWHR's endometriosis program. Again, we could not do this work without the expertise and contributions of our science networks, particularly the Endometriosis Education Working Group members who contributed to the development of SWHR's Endometriosis Toolkit for Teens. This toolkit is SWHR's first resource to be offered in both English and Spanish. It includes information about gynecologic health, diagnosis and treatment, and tips for talking with your healthcare providers and family about endometriosis. You can download this and other resources from our website at www.swhr.org. And we will be sending out an email with a recording of today's public forum to all registrants, as well as post a recording on the event webpage for future viewing. So please be on the lookout for that and feel free to share with others. Make sure to sign up for our newsletter so you can stay connected with us on all social media as we continue this very important conversation with #SWHR Talks Endometriosis. Thank you for joining us.